Idiopathic thrombocytopenic purpura in adults can become chronic, not in the case of the children. Coming to the coagulation disorders, hemophilia B may factor 9 deficiency is the challenge, is what you need to remember. So we give a infusion of the factor 9, not factor 8. So plexiform type of a pulmonary hypertension, where do you see, doc? Typically, you find plexiform pulmonary hypertension is familial. Interstitial lung disease due to chronic hypoxemia can lead to pulmonary vasoconstriction and can lead to pulmonary hypoxia. And any congenital heart disease also lead to chronic hypoxia leading to pulmonary vasoconstriction and lead to plexiform pulmonary hypertension, but not with thromboemboli. Whenever there is a child Puig's classification of score C, then it is associated with a very high risk in case of non-hepatic injury surgery. 37-year-old comes with a blurred vision and afferent pupillary defect is there, and after giving methylprednisolone her visual symptoms improved, and she has a pain while moving the eye, and her periventricular demyelinating plaques are seen, called Dawson's figures. So it is clear that she is a case of multiple sclerosis. Spinal cord involvement can very much happen in multiple sclerosis, and it can produce a mass lesion, and it is autoimmune. Oligoclonal bands can be found in the CSF. They are all the facts about the multiple sclerosis which you have to be doubly sure about. Now, what is the safest transplantation approach in case of the liver disease? So, transplanting the mesenchymal stem cells from the adipose tissue to liver is considered to be safest of all the options which are being given here. I am trying to run a little faster because you already solved the question paper, the NEET mock test that we have conducted every Sunday morning. That's the reason I'm not going very detailed, and very detailed it is very difficult to cover the subject in such a short time. The Sunday test is only an indicator as to where you are possibly going wrong, where you need to improve to face the exam. Post-operative ileus, it usually resolves within 48 to 72 hours, and on the radiographs you will find diffusely dilated bowels. You don't find the adhesions. Adhesions are not the cause of the immediate post-operative ileus. So then about secondary bacterial peritonitis, appendicular perforation can cause. Polymicrobial it will be, not one single organism will grow, and marked amount of leukocytosis. Complete blood picture only you can decide that it is a secondary bacterial peritonitis, is what you have to remember. This is for the earlier question. In a post-operative ileus you will find multiple dilated loops of the bowel but no air fluid levels. If air fluid levels are there, then you think of a small intestinal obstruction. But post-operative ileus typically multiple dilated bowels without the air fluid levels is what you have to appreciate. Now, intestinal ischemia, wherever the blood flow got affected, or if there is an atherosclerosis involving the small blood vessels supplying the mesentery, then intestinal ischemia can occur. So watershed zones between middle colic, left colic, so they are the ones which are affected, and crypts can become hyperproliferative. But if you look at the surface epithelium, it is the surface epithelial atrophy necrosis, sloughing with a normal or a hyperproliferative crypts, which is considered to be the histopathological hallmark of the intestinal ischemia. One of the favorite questions of the AIIMS PGI question bank, which if you are thinking in exam hall, maybe what is the reason, let me guess, no. You have to be very sure on this single statement. The surface epithelial atrophy, necrosis and sloughing, as what you can see here, with a hyperproliferative crypts or a normal crypts, is the hallmark of the intestinal ischemia, is what you have to basically remember. Colorectal cancer, right side versus left side. What are the differences in the clinical presentation? You have to be very sure about. So weight loss, weakness are the features of right colon. Whereas constipation, alternating bowel patterns, abdominal pain, decreased stool caliber and rectal bleeding, they are all the features on the left side of the colon, which is in continuity with the rectum, is what you have to remember. And tenesmus is a classical feature in case of the rectal cancer. Continuously patient will feel like going to the washroom, in spite of passing the stool, still he feels that something is not emptied. So that is tenesmus, is a feature of rectal cancer. In thyroid